Good morning and welcome back to Open School. Today I'll be discussing about localization in clinical neurology. Whenever a patient comes with a neurological problem, we have got three questions. Has the patient got a disease? If yes, where is the problem? And then what is the problem? What means etiology or the pathology? Where means the anatomical localization. So today's discussion is on this anatomical localization. The nervous system, as we know, divides mainly into the central nervous system and peripheral nervous system. Central nervous system is divided into the brain and spinal cord, and peripheral nervous system is outside the pia. Any neurological problem we will think in a hierarchical order. Is it a disease of the brain? That is, whether it is a cerebral lesion. Second comes the brain stem. Is it a disease of the brain stem? Third is it a disease of the spinal cord? Is it a disease of the nerve roots and peripheral nerves? Is it a problem with the neuromuscular junction? Is it a problem with the muscle? This is how we will analyze the symptomatology. So this is mainly based on the history. Investigations and imaging are not included here. So what are the features of a cerebral cortical lesion? We'll go step by step. Cortical lesions are characterized by, first and foremost, abnormal mental status. If the higher mental functions are abnormal, delirious patient, definitely they can say that the patient has got a cortical problem or a cerebral problem. So higher mental functions are important, disorientation or any abnormality. Second important problem which localizes is the presence of seizures. Seizures are hypersynchronous discharges of cerebral neurons. So if a patient has got a seizure, you can definitely say that the patient has got a cortical problem. Third is somebody with a hemiparesis with the sensory loss including head and limbs. A unilateral weakness with the sensory loss affecting the face is almost always likely to be there is a cerebral problem is there. But again, in cortical problem, the lesions are little more limited. You know the cerebral homunculus. So you get, that in the cerebral homunculus, suppose this is the cortex, coronal view. Leg is situated medially and the face is on the lateral aspect. And these are two vascular territories. Leg is by the ACA and the face is by MCA. So only an extensive problem can only produce dense weakness. So hemiparesis in a cortical lesion is usually limited. That is, either you get a facial paresis, faciobrachial paresis, something like that. So this is the second point we have mentioned. Third is very important, presence of speech abnormalities, that is aphasia. So language dysfunction localizes the problem to cortex. Other cortical dysfunctions like corticosensory loss, apraxia and agnosia also favors cortical lesion. Then visual field abnormalities like hemianopias. Homonymous hemianopia means the lesion is retrochiasmal. So it's again favors a cortical cerebral problem. Movement disorders, the extrapyramidal involvement, or patient with a diffuse coordination abnormalities, tremor, chorea, all favor a cerebral lesion. In the cerebrum, I have included the cerebellum also. Along with the cerebrum, I have included the basal ganglia and the cerebellum also. Now we go to the next order. It's a brainstem. What are the features of brainstem involvement? The classical finding is crossed hemiplegia. So what is my crossed hemiplegia? Ipsilateral element type of cranial nerve involvement and contralateral weakness is called crossed hemiplegia. It can occur at the level of the midbrain, at the level of pons and the medulla, which will be discussed at a later time. So crossed hemiplegia is a characteristic. Second is cranial nerve involvement, single or multiple, especially if associated with a long tract sign. By long tract sign, what I mean is some pyramidal findings in the lower limbs. It is a favors a brainstem involvement because cranial nerves are windows to brainstem. So brainstem involvement, because the cranial nerves are arising in the brainstem, it is usually associated with some cranial nerve abnormalities. Next level is spinal cord. The spinal cord lesion, the pathognomonic finding will be a sensory level. A patient with a sensory level on the trunk with weakness. So somebody has got a cross section of the transverse lesion of the spinal cord, they will get a paraparesis with a sensory level. Paraparesis with a sensory level on the trunk is almost pathognomonic of a spinal cord lesion. In addition, patient can have back pain. So especially with the radicular pain around the trunk. So the patient says, I want coughing, I get a pain around my trunk, either unilateral, bilateral. It suggests there is a local problem there, and if there is a weakness below that level, there is a paraparesis, definite evidence of a spinal cord involvement. Another important finding is the mixed UM and LMN findings. So suppose you are getting upper motor neuron plus lower motor neuron findings. For example, wasting and weakness of the hand muscles with quadriparesis. It is always indicate a cervical cord lesion. So LMN plus UMN lesion can occur in the syringomyelia. But again, remember, motor neuron disease can also present like this. Then sphincter dysfunction. Spinal cord lesions usually produces with significant weakness. There will be evidence of bladder involvement. So these are the major features of a spinal cord lesion. Now we come to a root lesion. Spinal root, the classical feature is the radicular pain. So what is radicular pain? That is the root pains. Radicular pains are sharp, shooting or a lancinating or electric shock-like sensation that goes along the nerve root. Suppose it is C5, you will get along the shoulder like this. So this pain aggravates on coughing and sneezing. Anything that aggravates the intestinal pressure will produce worsening of this. That is one of the characteristic features, radiating pain like this. Weakness, wasting or other element findings in the distribution of that nerve root. For example, CAT1, you will get wasting of the small muscles, and you can get sensory loss along the distribution of the CAT1. Again, that is a definite evidence of a root problem. Then, of course, you check the reflexes. So depending upon the reflexes, the root values, for example, C5, along with a radicular pain, you get a biceps jerk is absent. It is suggestive. So think about the reflexes. Then comes the peripheral nerves. There are different types of patterns of sensory loss. due to peripheral nerve disease. A single nerve in the distribution of that nerve, that is mononeuritis, multiple nerves. And another characteristic finding is the stocking and glove distribution of sensory loss in distal symmetrical peripheral neuropathy. That is, longest neurons are affected. So, a patient complaining of numbness of the hands, numbness of the legs, often starts in the lower limbs before affecting the upper limbs. That is a length-dependent sensory stimulus, stocking and glove distribution of sensory loss. Again, very characteristic. Of course, the reflexes are going through the sensory neurons. So, in the peripheral neuropathy, there will be loss of reflex, especially the ankle jerk will be absent. So, usually the sensory symptoms in peripheral neuropathy depends upon the nerve which is affected, or it is as a part of distal symmetrical peripheral neuropathy. You can get bilateral symmetrical stocking and glove distribution. Next comes the neuromuscular junction. The classical disease is the myasthenia gravis. All of you know, often 95% of the patients comes with ptosis, diplopia and other ocular symptoms. No sensory complaints will be there. So it's bilateral, includes the face. Typical finding is ptosis and diplopia or dysphagia, and can have proximal limb weakness. And the characteristic finding is as the patient exerts, the fatigability increases. So on exertion, the weakness will be more. So it is a fatigability will be there. The morning patient may be better. In the evening they develop ptosis. No sensations, sensory loss or sparing of sensation. Presence of sensory loss along with it excludes neuromuscular junction disease. Typical example, myasthenia, but you can get in snake bite or muscle poisoning. Now finally comes the muscle. Muscle disease is characterized by bilateral, symmetrical, proximal. Usually, some days in distal muscle weakness can also occur, and no sensory loss, long duration. So this is how you localize problems with the different parts of the neuroaxis. Then from this you will think about, is it a CNS involvement or a peripheral neurosystem disease? And so this is just an introduction to localization depending upon the symptomatology. Hope this was useful to you. Stay tuned for further videos. Thank you.